Antidiuretic hormone, or ADH, and arginine vasopressin, AVP, are the same compound, and people will use them interchangeably, and I will use them interchangeably in this talk as well. I'm not going to read these. I'm going to leave these up for a couple of seconds. You can always pause the video and read these bullets on water transport. There's one on AVP or ADH, and on aquaporins. These are water channels. On the basolateral surface of an epithelial cell, we see fixed aquaporins. These are numbers 3 and 4. These are always open, and there could easily be 1 million aquaporins on the basolateral membrane of each cell. On the apical membrane, we see a different aquaporin called aquaporin 2, and this aquaporin is under hormonal control. And that hormone is ADH, or AVP. It's the same thing. The basolateral surface contains receptors for ADH, a V1 and a V2 receptor. The V1 receptor stimulates the production of IP3, which causes calcium release from the endoplasmic reticulum, which is involved in the fusion of vesicles to the membrane through exocytosis. The V2 receptor stimulates the production of cyclic AMP, which triggers protein kinase A to begin the process of synthesizing more aquaporins, and pKa also phosphorylates these aquaporins, promoting the trafficking to the membrane. These aquaporins are recycled. When we need them, they are placed on the membrane. Under conditions when we don't need them, they are removed from the membrane and brought back into the cell, where they can be then moved back to the membrane. On occasion, however, a protein called ubiquitin attaches to the aquaporins, and that protein marks these aquaporins for destruction. In this figure, I'm looking at the tubular fluid over here in the collecting duct. We have a capillary, a basilar membrane, and these two epithelial cells. On the basal side, we see the aquaporins 3 and 4. They're always open. Water is free to move in either direction through these aquaporins. If you are hyperhydrated, you have too much water, your plasma is very dilute, we turn off the production of antidiuretic hormone. And in conditions of low ADH, these aquaporins attached to vesicles are not fused with the membrane. They may be pulled back in from the membrane, leaving very few, if any, aquaporins on the apical membrane. Without aquaporins on this, water is not free to move into the cell, through the cell, and exit the basal surface, entering the plasma, and exit the basolateral surface and re-enter the plasma. So in this condition, we want to lose water to bring our blood volume back down, to bring our blood osmolarity up. However, in the condition of dehydration, which would be low plasma volume, high plasma osmolarity, we want to reabsorb as much water as possible to bring our plasma volume up and to bring the osmolarity back down. So under these conditions, we move the aquaporins to the membrane, fuse with the membrane, and now we have a free pathway for water to flow into the cell, out the other end of the cell, and back into the plasma. So antidiuresis occurs under high ADH, diuresis occurs under low ADH conditions. The next animation is fusion of a vesicle with the membrane. In this animation, I have a very slow motion in which I'm fusing the vesicle with the apical membrane. The aquaporins are now on the membrane. The water is free now to pass through the aquaporins, through the cell, back out the basolateral side through the fixed aquaporins, back into the plasma. Under dehydration with high ADH, we have maximum reabsorption of water and minimum excretion of water. Now the next animation is going to be a low ADH condition, also in slow motion. So here we're seeing the aquaporins being removed from the membrane. A vesicle is created, the membrane is refused. Tubular fluid here has no way to pass through the membrane, through the cell, back into the plasma. So under these conditions, water has nowhere to go but through the collecting duct to the ureters and into the bladder for excretion. In the hypothalamus, we have osmoreceptors, and these receptors are actually located outside the blood-brain barrier so they can sense the tonicity of the plasma. In this condition, we have hypertonic plasma. We have sodium channels on this membrane. Water will move out of the cell into the plasma through osmosis, and as the cell shrinks, sodium channels open. We see a high rate of action potentials down the neuron that triggers increased ADH secretion, antidiuresis, and an increase in thirst. In a hypotonic plasma, water moves into the cell through osmosis. The cell swells, sodium channels close, action potential frequency decreases, and that causes a decrease in ADH secretion and diuresis. In this figure, I'm looking at plasma osmolality on the x-axis and plasma ADH on the y-axis in arbitrary units. The osmolality is normally about 285. This varies from person to person, but on average about 285 milliosmoles. So we have tonic secretion of ADH. If the osmolarity now decreases, we see ADH secretion decreasing and eventually completely shutting down. If osmolarity increases, we see an increase in ADH secretion, and at this point we trigger our thirst sensation. But plasma osmolality is not the only trigger for ADH secretion. If we see a large change in plasma volume or plasma pressure, we can begin to see ADH secretion. So here we are at normal. Now we're looking at about a 10% reduction in pressure or volume. We begin to see an increase in ADH secretion. So in this situation, we want to bring back our blood pressure, our blood volume, so we bring back water. In this figure, I'm showing the normal condition. Here we are again at 285 with our basal level of plasma ADH secretion and increasing and decreasing osmolality and its effect. If there's a 15% decrease in plasma volume or plasma pressure, we see a steeper slope, much more sensitive system to osmolarity, and a shift downward toward a lower osmolarity. If our blood pressure is low and our blood volume is low, we want to increase the sensitivity to ADH release. Much lower osmolarities will trigger ADH secretion, and the sensitivity is also greatly increased. On the other hand, if we're hypervolemic, hypertensive, we want to decrease the sensitivity of these osmoreceptors to plasma osmolality. So we'll now see a shift to the right toward a higher osmotic pressure and a much less sensitive system. In the proximal tubule, the fluid is isosmotic with plasma. So in this instance, we're looking at about 285 milliosmoles per liter, and it's in the proximal tubule. As we move down the descending limb of the loop of Henle, we begin to see the concentration of tubular fluid increase. We turn around and we start moving up the ascending limb of the loop of Henle. We begin to see the loss of sodium, and therefore the tubular fluid is being diluted. By the time we get to the distal portion of the tube, we are now at about 100 milliosmoles. In the total absence of ADH, in the collecting duct, cortical medullary collecting duct, water cannot be reabsorbed. Some electrolytes are still being reabsorbed, but water cannot be reabsorbed. So we have a very dilute urine down here, could be down at 50 milliosmoles. Our urine output is now greater than 15 liters per day. To put that into English units, that would be about 4 gallons of water a day. Under maximum ADH secretion, we're now in the cortical collecting duct. At this point, we're beginning to reabsorb water, but since we're in the cortex, there's no concentrating ability. The best we can hope to do is to become isosmotic with plasma. But once we get down into the medulla, we start moving down the collecting duct, water's being reabsorbed, and eventually we reach a maximum reabsorption in which we are in equilibrium with the surrounding fluid. So the osmolarity collecting duct is the same as the osmolarity in the surrounding fluid. And in this situation, we could urinate far less than 1 liter per day. In fact, half a liter is not uncommon. And to put that into English units, a half a liter would be about a pint per day. Now let's look at it in the real world. This individual is dehydrated, has a high plasma osmolality. We're up around 310, 320 milliosmoles. We're in antidiuresis. We want to try to conserve water. GFR is very low because of the low pressure and low volume. So as we move down the descending limb of the loop of Henle, the fluid is in the loop long enough to cause enormous concentration. As we rise up the ascending limb, we again dilute. We're back down here now, maybe at about 200 or so milliosmoles. We enter the cortical portion of the collecting duct, and we see our tendency to rise back up to plasma osmolarity. Now we're moving down the medullary collecting duct, and we're concentrating until we reach a point of equilibrium. So under dehydration, we maximum increase ADH to increase water reabsorption. The concentration is the result of the low flow through the tubule, allowing more sodium to be pumped out, increasing the concentration of the surrounding fluid down at the elbow of the loop of Henle. This individual is hyperhydrated, too much water, down here at 260, 270 milliosmoles in the plasma. Now this individual is under conditions of diuresis. Get rid of that water. We have a high GFR, high tubular flow, and under high tubular flow, the fluid is not in the tubule long enough to create high concentrations in the surrounding tissues. Now we're coming up the ascending limb. We're in the distal convoluted tubule. We get into the cortical collecting duct, the medullary collecting duct. This individual is not producing ADH. We have a high urine flow. This individual is attempting to get rid of this excess water. There is a problem, however, that occurs with ADH, and that is a condition called diabetes insipidus. And this has nothing to do with sugar. This is strictly ADH secretion. If we deprive a normal individual of water at this point, we're looking at somewhere around 282 milliosmoles, and we deprive them of water, we see a gradual reduction in urine flow until we reach a point in which there's maximal ADH being secreted and we reach a point of steady state. Diabetes insipidus comes in two forms: central diabetes insipidus, that is inadequate release of ADH, and nephrogenic diabetes insipidus, and that is the inability to respond to the ADH that's present due to a defect in the aquaporin 2 gene. So in this individual, you deprive them of water, we see very little change in urine flow. They cannot reabsorb the water. There is a test, however, for these two types of diabetes insipidus. If we inject arginine vasopressin, ADH, into this individual, and we see a rapid reduction in urine flow, this must have been central diabetes insipidus, because this individual is responding to the ADH. However, if we inject ADH at this point and we see no or little change in urine flow, this individual is suffering from nephrogenic diabetes insipidus. Even if the individual is producing ADH or we inject ADH, the cells are not responding to the ADH. The aquaporin 2 gene is defective. We're not able to reabsorb water. Some water transport defects include, as I mentioned, diabetes insipidus. This is central diabetes insipidus, which is the inadequate release of ADH, leading to excess water loss and thirst. Defects in the aquaporin gene, I mentioned, is nephrogenic diabetes insipidus. Aquaporin 2 expression is also increased in pregnancy and in congestive heart failure, causing water retention and edema. And for those of you who've been to a bar, you may notice that there are long lines at the bathrooms, and that is because ethanol blocks ADH. This causes diuresis. And, by the way, the next morning, the reason why your mouth is dry, you're unable to salivate, is because you're dehydrated, and you're thirsty because you're dehydrated, and you have a headache because you're dehydrated. Pituitary tumors may cause hypersecretion of ADH, and this will lead to water retention and edema. I've shown this target. If you've seen some of my other talks, I've shown this target. This is where we want to try to be. If our volume is too high, we want to try to bring it back down. If it's too low, we want to bring it back up. If we are too concentrated, we want to move toward this target, and if we are too dilute, we want to move back. If you've listened to my talk on atrial natriuretic peptide, this is the hormone that's released when volume is too high. Atrial natriuretic peptide causes sodium excretion and water excretion, and that brings our volume back to our target. If you've listened to the renin-angiotensin-aldosterone system discussion, you will notice that under conditions of too little volume, the system produces aldosterone, which causes sodium and water retention, bringing our volume back up to our target. In this talk, we discussed ADH. Now, ADH is responding primarily to osmolarity. If our plasma is too concentrated, we increase ADH secretion, bringing back free water, diluting plasma, trying to bring it back to our target. If, on the other hand, we're hypoosmolar, too dilute, we decrease the antidiuretic hormone production. That causes excess water excretion, bringing our osmolarity back to our target. That concludes this talk on antidiuretic hormones.